I've tried to be a bit fancy and included a QR code that if you're able to scan it should take you to the PowerPoints via Google Docs, and the PowerPoints on Google Docs have all the links that I'm going to talk about. So hopefully that works. I'm not sure if everyone's too far away. But yeah, I'm a psychologist by background, and psychology is my background, and I'm an academic by trade, so I'm not a clinician. But as Tom said, I spent a lot of time in the UK doing TSC research, so I travel around the UK. I think I met around 60 young people with TSC and their families, and I've worked alongside a lot of mental health and intellectual disability nurses and clinicians, and I also have carried out a lot of standardised assessments for autism, so the Autism Diagnostic Interview and the ADOS, and for ADHD, and carrying out lots of cognitive assessments with young people and with a lot of young people with TSC. So that's my kind of background. So I'm just going to kind of do a bit of an introduction to TAND, which is the nice way of saying TSC associated neuropsychiatric disorders. I think it should be double D. I think it should be disorders and difficulties, because not everybody reaches the criteria for a disorder, but a lot of people do have different difficulties that affect their everyday lives. So I'm just going to talk about what we mean by these disorders, what other difficulties people experience. I'm going to talk a bit about the TAND levels and clusters, because Petrus, who's a psychiatrist from South Africa, has sent us a special video where he's going to talk about the research that they've been doing and some amazing developments that we hope will reach us soon in terms of tools that we can use for TAND. And I'm going to talk specifically about kind of what's available in New Zealand. So I've tried not to repeat too much of the talk that Petrus gave in Wellington for TSCNZ back in 2018, because his slides or his videos are all available on YouTube. So I highly recommend watching those, because he's an amazing speaker, and you'll see that when you watch the video that he sent for this year's conference. I also really strongly recommend looking at the TS Australia website, because they've got an amazing section on TAND and links to a lot of the checklists and the research and just what we mean by TAND. And you can see they've expanded it a bit as well to make it clear that we're talking about a really broad range of difficulties that people might have that are associated with TSC. So for me, and this is true for TSC in general, it's true for neurodevelopmental disorders and mental health disorders in general, the first step is awareness and recognising, getting that assessment to understand an individual's strengths and difficulties, to see if they do meet diagnostic criteria, and then that can be used to tailor support and intervention. And there is some evidence, and I'll talk about this at the end, that we might be able to, by treating TSC early, might be able to prevent some of these neurodevelopmental disorders from developing in the first place. So I just want to talk a bit about neurodiversity and how our understanding of neurodiversity in general and in TSC has changed over the years. So in the past, if we think about how people's cognitive abilities, I think there's a pointer on here. A lot of the time, I'll come up here. No. A lot of the time, it was assumed that most people had a relatively flat profile across different areas of cognitive ability, and that the people that clinicians were most interested is people that were kind of down this bottom area that had a lot of difficulties in that area. And it was assumed that most people with TSC were down here, that most people with TSC had significant cognitive disabilities or intellectual disability. But much like we're seeing with autism, I think that's probably because data were only being collected on people who had quite severe forms of TSC, who were experiencing intellectual disability or had cognitive difficulties. And actually there's a lot of people, going around with TSC that don't realise they have TSC or don't have any of these difficulties that weren't being counted in that data. So actually, we now know that there are a lot more people than we thought who have TSC, but are, functioning in the same way as most people in the population. So that's one key thing that I think has changed over time. The other thing is this better understanding in general and in TSC that we have a group of people who have what we call this spiky profile or an uneven profile. And where, they do very well in some areas, maybe they've got a great memory, but their social skills are not so good, or their attention span is not so good. And some of those people will fall into this kind of difficulties area in some domains, but in their other domains, they'll be right up here. And before those people weren't really, we see that a lot in autism in particular, and before those people weren't really catered for in terms of services, because it wasn't recognised. They were seen as high functioning. It seemed like they were doing well because they had some really good strengths, but actually there were some areas where they were really, really struggling. And so when we think about neurodiversity, we're not just thinking about, people who have significant kind of cognitive disabilities. We're also thinking about people who themselves are very neurodiverse. They've got really good strengths in some areas and not so much in others. So just also want to make some distinctions. I'm going to be making a few distinctions and kind of demystifying maybe, or providing definitions for the way that most, I guess, clinicians think, but also what some of these terms mean. So we have, physical health problems like TSC and epilepsy that have an impact through genes and perhaps through the environment, have an impact on our brain, and might also then lead to or be associated with cognition, emotion, behaviours. And we tend to group them into two different types, although there is some crossover. So we have developmental problems. These are things that are evident or develop from very early in childhood. They tend to be lifelong. There tends to be some treatments or interventions that can help, but they don't necessarily take the core problem away. So, we don't have a cure for autism. We can support people with autism with their difficulties, but we're not really going to be able to take away those core difficulties that they have. And that contrasts with mental health problems, which tend to have quite a specific onset. So somebody is doing okay, for whatever reason, something happens and they develop a new mental health problem, tend to be episodic, can come and go, and most of the time a treatment will kind of remove that core problem. That core problem will be taken away, treatment can be stopped, and hopefully that problem doesn't come back. I consider all of these, both developmental and mental health problems, to be an indication of neurodiversity. For me, there's so many crossovers between these disorders that they're the same thing to me anyway. So I think actually if we think about who is neurodiverse, when we think about how many people there are with an developmental or mental health problem, it's actually not very unusual. There's probably, I don't know how many people in this room. I'm not going to ask you to put up your hand. I know within my own family we've got 30% of us have at least one of these. So, and quite often people have an individual has one or multiple problems, and that can cause lots of difficulties in terms of how they're able to function day to day, in terms of the impact it has on a person's everyday life and their family's lives. I just wanted to go through a few misnomers, or just to show again how things have changed over time and how we now understand neurodiversity a lot more. So in the not that long ago, 20 or 30 years ago, it was assumed that most people with autism also have an intellectual disability. As we've got better at diagnosing autism and recognising autism in people who don't have an intellectual disability, but that is changing. And actually, I don't actually know the most recent data because it's changing all the time, but it's now we have a lot more people with autism who don't also have an intellectual disability, who we might refer to as high functioning, though that can be misleading because they might have some really difficult issues in some areas. In the very early days, in the 60s and back when Canna was describing autism, it was really thought that girls and women are less likely to have autism and ADHD. And we're still seeing that a little bit. There might well be some underlying reasons why men and boys are more likely to have autism and ADHD, but what we're really learning is that actually many girls and women can have autism and ADHD. They're sometimes just a bit better at masking some of the classic symptoms. Don't forget, all these diagnostic criteria for autism and ADHD were mostly based on research on boys. They didn't include girls. And so we've missed a lot in the way that we view what we see as being autistic or what we see as being symptoms of ADHD. That is changing, thankfully, but it's still a struggle to get diagnosis for girls and particularly for adult women. Two kind of contradictory ones here, but a lot of people in the old days were told that their child would grow out of autism and or ADHD. So there is, for autism, that doesn't seem to be the case at all. For ADHD, some people do find as they reach adulthood that their symptoms go down and they are able to function a lot better. But for a lot of people, it is a lifelong condition. So then we also had, once we realised this wasn't the case, a lot of people kind of assume that, if you have difficulties, or rather, if you don't have these kind of difficulties as a child, you're not going to suddenly get them as an adult. And while it's true that you don't have a kind of adult onset of these disorders, what we do find is that people who have got particularly ADHD, they might kind of get along very well as children. They might have some inattention, some hyperactivity, but they manage to deal with it because their demands on them are not that high. You're in a school, you're in a structured environment, you're living with your parents. But as young people get older and their life becomes less structure, there's more pressures on you, and even, going up until, adulthood, where suddenly people, are really under a lot of pressure because they've got so much going on around them, that's when they start to struggle with those difficulties. So the difficulties were always there, they just were able to cope with them much better. So you do find this is happening a lot with ADHD, that you have people who would have been very successful, done very well, but reach a point where suddenly the difficulties they've always had with concentrating and impulsivity become too much, and they might then seek a diagnosis. So that kind of comes back to this idea that neurodevelopmental difficulties can only be diagnosed in childhood. It is still very difficult to get a diagnosis in adulthood, but it is possible. Sometimes quite often you need some background history to demonstrate that you have had these difficulties from an early age. They might not necessarily have affected you that much, but we can now, clinicians and services should be assessing and diagnosing adults, especially those who might have missed out on, might have been at school during the period where these disorders weren't being recognised and weren't being identified. It took a long while to convince mainly psychiatrists that people with intellectual disability and autism in particular could also have mental health problems, could experience anxiety, could also be depressed. And I think that's has been a really difficult time, or that was a very difficult time, because it meant people were suffering with mental health disorders that were treatable. So they might have been acting out, they might have been very, very distressed because they had developed an anxiety disorder that is treatable, that could have been, alleviated by the same treatment that most of the general population get. And it was dismissed as that's just part of their TSC, or that's just part of their learning disability, that's just part of autism. We know we shouldn't be accepting that feeling or exhibiting these symptoms is necessarily, inevitable. There's things we can do about that. This is until quite recently, and actually my nephew has been diagnosed with ADHD, and the paediatrician told my sister and brother-in-law, just give him medication. Talking therapies don't work for ADHD. And she came home and told me this. I was like, oh my God, because while standard psychological therapies might not necessarily work very well for people with intellectual disability, people with autism, people with ADHD, if they're done well and if they're adapted and if they focus on some of the specific difficulties that people who have those conditions, especially if they have those conditions and anxiety and depression, then actually they do work. And there's been some good work on adapting those therapies for people with autism, for people with intellectual disability. I actually worked on a like self-help book we worked on in the UK for people with intellectual disability who have anxiety or depression. So these kind of therapies we shouldn't just be dismissing people again, saying we can't treat them for their mental health condition because they have a neurodevelopmental disorder. A lot of people get this as adults. I have experience with this myself a little bit. You can't have autism, ADHD. You're too funny. You're too social. You've been to university and you have a successful job. You can't have these conditions. Not true. Again, we know people can be very successful. They can do really well. People with autism can be hilarious and very social. But again, there's areas in their lives that other than that they have real severe difficulties. And like I've said, it might be that someone is very successful, but it's because they've been able to cope with some of their difficulties up to a certain point. And this one, I'm not going to go on this, I could talk about this list forever and ever, but this idea that all of the behaviours we see when we think about neurodevelopmental, psychosocial, mental health difficulty, all the idea that these individual behaviours are abnormal. All the behaviours we see in neurodevelopmental disorders are things that everybody experiences. Everybody worries every now and again. I have a few odd routines where I like to touch, I could go on. Even, hallucinations that we see in schizophrenia. Quite often people who have no diagnosis of mental health problems hear things or hear voices or experience some sort of hallucination. So these are all things we see in the general population. So they're not completely abnormal. It's when they cluster together and when they have a significant impact on someone's life and their functioning and those around them that it becomes an issue and that we might say they have a disorder. So we've got, Petrus is going to talk a little bit about this, but I wanted to just sort of talk about how this whole idea of TAND came about. So it kind of started from an academic and clinician point of view. So academics and clinicians looked at some of the common difficulties that people with TSC had, and they put them into these categories, these levels. So this is like their way of grouping these together. So I think this makes sense as well, to some extent, but we see a lot of crossover. So we've got kind of behaviour, this is where our behaviour kind of reaches that diagnostic level. We might actually have, a disorder. We might have our cognitive difficulties, might be enough that we have an intellectual disability, might have some of these issues. So that was very much what we call a top-down. So it came from the academics on their pedestals. And from this, the TAND checklist was developed. So this is available on the TSC New Zealand website. And what the researchers did then was they got as many people as they could to complete the TAND checklist. And then they looked at what kind of items on the checklist were people endorsing, saying they did experience, and how did those group together. So then we end up with this more, which is bottom up. So this is driven by data from people with TSC. And some of them do match those levels, but this is what we tend to find is that people tend to have a high level of difficulty in one of these areas, or more than one, but these tend to be the main clusters. So they are slightly different, and I think if you look at that the talk that Petrus gave in 2018, he goes into a lot more detail on this. But I'm sure you can all, I'm sure you can all recognise we all have these. I don't often have a temper tantrum, but every now and again one of my students annoys me so much that my flatmate bears the brunt of it. But these are things we all might have difficulty in. So I just wanted to kind of go into what if we know someone, a child or an adult with TSC has these reading, writing, numeracy difficulties, we should be thinking about an assessment and possible, diagnosis for these conditions. So actually pretty much everything we should probably check for if someone's having difficulties with those. If their behaviour is dysregulated, so they have trouble controlling their behaviour. Really, the key thing here is, first of all, before we think about any diagnosis, we need to try and understand what's the meaning and function of those behaviours. Does it indicate that a person is frustrated, uncomfortable, in pain? Maybe they're not able to communicate. So there's likely to be a lot of other things driving this dysregulated behaviour besides or in addition to having a disorder like autism or ADHD. If somebody has new symptoms, changes in behaviour, in their mood, or whether they appear scared, or if they have less energy than normal, we really should be thinking about, do they have an additional mental health problem, especially if that's a new behaviour. If they've got social difficulties, again, we probably want to, get to the bottom of that. What specific difficulties are they having? Is it something that really kind of corresponds with autism, or is it more related to ADHD? People with ADHD do often have a lot of social difficulties because of their impulsiveness, because of their hyperactivity. And really, the thing we should be doing first is, if somebody is showing any of these type of symptoms or signs, is it something in their environment? Are they uncomfortable? Are they having sensory issues? Is the lighting too bright? Is it something to do with their seizures or their medication? Is it another physical illness? We really need to be thinking about, is it their diet? Is it they're not getting enough sleep? So these things really, I think we need to think about all the time before we start, carrying out assessments to rule them out. You'd be amazed how many times, maybe not, you won't be amazed, but how many times people go to the doctor with symptoms of depression, the doctor doesn't say to them, how's your diet? Are you getting any exercise? Are you sleeping? What's your menstrual cycle like? Doctors just go straight to the depression diagnosis without ruling anything out. I do as well, probably a lot of you do know this, but every time I speak to someone about my research, they're like, so what is a psychologist and what is a psychiatrist? And this, I think, is the simplest way. Psychiatrist is a medical doctor who's undergone general medicine training and then specialised in psychiatry. Psychiatrists do diagnosis and treatment mainly with medication. So they might carry out the initial assessments, provide a diagnosis, and then if required, they are the ones who can prescribe medication. Sometimes they do carry out psychological therapies, not that often. More often they'll be referring to a psychologist. Psychologist is not a medical doctor, but they have a doctorate in psychology. So they've undergone psychological training, a lot have a PhD as well. They cannot prescribe medication. But they provide, psychological therapies like cognitive behavioural therapy and all of the other kind of talking. But they're different. So a counsellor might have a different type of degree. They've got training in counselling, which is a lot different. It's not as structured, it's not as much of an evidence base as some of these psychological therapies like CBT. So this is where we struggle in New Zealand, because we're quite restrictive in New Zealand about who can diagnose these issues. And the older you get, the harder it is. So for autism, intellectual disability, ADHD, some of these quite severe behaviour disorders, it's really got to be a paediatrician, a clinical psychologist, or a psychiatrist. If you're diagnosed with ADHD by a psychologist, you're unlikely to be able to then get any medication because it's a psychiatrist who prescribes medication. It's not always the same. I think it's different in Canterbury for some reason, but there's a big issue there with accessing these services in order to access treatment. If you have any kind of cognitive or intellectual difficulties, you might be seen by a neuropsychologist who does lots of different tests. That's really to identify strengths and difficulties, because we do know that everybody will have different levels. There'll be some things, and we can play into those strengths when we're helping young person develop, or when we're helping them to be maybe more independent, when we're trying to decide, what is the best intervention for that person. For learning disorders like dyslexia, dyscalculia, dyspraxia, we're looking at educational clinical psychology. Behaviour problems, generally a behaviour therapist or psychologist. So these will all be trained psychologists, just different types. For communication disorders, speech and language. For mental health problems, GP should be, GPs can diagnose most mental health problems. They might not be able to prescribe all medications. They might need to refer you on. But this is just for TAND, right? And I'm cognizant that for TSC, you've also got all those other ologists. And so it's really quite a minefield. Just want to talk about a bit. So really for ADHD, medication is the first line treatment. But there is evidence that cognitive behavioural therapy, ADHD, coaching, these type of interventions can help people with ADHD, although they do tend to work better when they're in conjunction with medication, because medication just kind of brings you down to that level that you can engage more. But certainly medication is not for everybody, but that is the kind of first line treatment. For autism, we're getting a lot of these early intervention models that are about naturalistic development, encouraging children to play, encouraging them to communicate from a very early age, from as soon as possible, even before they get a diagnosis if possible. We've got adapted CBT for anxiety. A lot of work has come out since COVID about providing teletherapy for people with autism, because, especially if they have anxiety or depression, because it's a bit more comfortable environment than going to a doctor, talking to someone in person. A lot of people find telehealth. Not going to mention these too much. Behaviour problems. In New Zealand, we follow the positive behaviour support, which is a little bit different from applied behaviour analysis, but there's still some controversy, especially among the autistic community, who worry that what's happening with behaviour supports and behaviour interventions is they're being asked to be normal and being normalised, and that their individuality is being taken away. So I think this really should positive behaviour support, applied behaviour analysis, really for people whose behaviour causes them difficulties, not because they don't give eye contact and everyone thinks they should be giving everyone eye contact. It shouldn't be about normalising people. It should be about allowing them, providing tools for them and their families to deal with difficulties that actually cause problems, not to make everyone else feel good about themselves. And for mental health problems, we've got psychological therapies and medication. So these are some really amazing resources where you can find out a lot more information. So we mentioned earlier mTOR inhibitors. So we know that sirolimus and everolimus are available in New Zealand for specific disorders. And there was some thoughts, and there has been some trials looking at whether mTOR inhibitors also have a positive impact or can prevent neurodevelopment, or TAND. To be honest, it doesn't look like in and of themselves they have an impact on neurodevelopmental disorders. But what they do, if they are able to have an impact on seizures, and if they're able to reduce SAGA, and maybe even if they're able to reduce angiofibromas, those things certainly do have an impact on TAND. So you wouldn't give somebody an mTOR inhibitor if they didn't have AMLs or epilepsy or SAGA. You wouldn't give mTOR everolimus to somebody specifically to treat their neurodevelopmental difficulties. But by treating these other conditions, you might well improve their outcomes in terms of their development. And that's because of some of this latest research on TAND. So we have this evidence that people with TSC2 variation are more likely to develop neurodevelopmental problems. And up until quite recently, we really didn't understand this pathway. So we knew that obviously mTOR was an influence as well. And we knew that whether or not you had TSC2 or TSC1 had an impact on your tuber load. It also had an impact on your seizures, and there's some connection here too. And it seems like all of these things have an impact on whether you, or how likely you are to develop neurodevelopmental disorders. But we didn't really understand this pathway very well. Actually, it looks like, so this is a bit oversimplified, but it looks like, particularly the mTOR pathway, in conjunction sometimes if you've got TSC2, but that mTOR pathway impacts tuber load in the brain. And it's that tuber load in the brain that impacts seizures, and it's the severity and occurrence of the early occurrence of those seizures that impacts neurodevelopment. So it looks like we've got this cascade of difficulties. Not a good thing, but the kind of advantage of knowing this is if we can diagnose tubers, or TSC in general, tubers, if we can prevent seizures, or we can provide early intervention for seizures very, very early on, as soon as possible after birth, we might be able to then prevent these neurodevelopmental disorders from developing in the first place. Some people will, in the general population, there are people with autism that, some people will always develop these, but we might lower that number of children, or proportion of children that end up experiencing autism or intellectual disability. But it is all about that early intervention. Some other recent research, I thought this was really interesting. So there's some evidence that children with TSC and children without TSC, whose mums have TSC, those children are more likely to have what are called perinatal adversity. So that's like things going a bit wrong during pregnancy or post-birth. I think there's a whole load of factors, and I'm not a paediatrician, so I don't fully understand them. But those are things that can have an impact on later outcomes. But actually, in TSC anyway, it doesn't make any difference. Children with perinatal adversity have the same likelihood of developing neurodevelopmental problems as those without that perinatal adversity. So it's probably actually, so if you're a mum and you have a child with TSC or you have a child without TSC, it's not your TSC that determines their neurodevelopmental outcomes per se. It's probably their TSC that's going to have that impact in terms of tuber load. I think that's why we see such variation, right? Where we have mums with very mild TSC and babies with who are quite severely affected. The other thing we do know is that infants with TSC and autism show some really early signs that there are issues with their development and their social communication. And we should be screening for autism. Once we know a child has TSC, we should be screening from 6 months, I would go for. And there's tools we can use to do that now. We should definitely be from 9 months really focusing, because again, for autism, the earlier we can provide support to families, the earlier we can provide support to kids, the better their outcomes are going to be. We're never going to take away their autism, but their outcomes in terms of how independent they can be, etc., are going to be really improved. In my slides, I haven't listed them all here, but I have gone through and had a look at all the different, it was bewildering, honestly. So those are in the slides. I'm not going to go into them now, but how I found the best place to look was Health Navigator. That was a really good source. And I've also had all these lists because we know that a lot of the time you're going to have to be looking for your own clinicians. They're not going to be found for you because we don't have those coordinators. And unfortunately, it does come to the point, especially if you're an adult and you think you might have autism or ADHD, it's very difficult to get that done in a public system. So you might well need to look at private providers. And I always say to people, don't just Google psychologist Wellington, because you get all sorts of things come up. But if you look at, these are like the actual boards. So this is the Psychological Association New Zealand. They've got everybody who's a registered psychologist in their database. And this is a really cool one. You can look at what particular difficulties someone's got, what area you're in, whether the person's a child or an adult, and it will show you all the clinicians in that area and you can look at what modalities they use. Do they focus on CBT, or do they focus on interpersonal therapy, or whatever you think might work for you? The same with a lot of these. These are all from those kind of official board, the people that train people. I always say to go to these first, because if you start Googling, you never know. And I would always go on recommendations from other people as well, because other people's experience with a clinician is really, really valuable. There's some really cool digital support, and Petrus is going to, in his video, tell us more about some exciting stuff that he's doing. Apps seem to work quite well for mental health difficulties, particularly with young people who like their apps. This is a really cool tool that's come out of Australia, AS Detect, that you can use to assess your own child for indications of autism from a very young age. Help is in Your Hands is an American app, but I think it's available here, which is based on that Early Start Denver model. So really good for young kids. It's basically how you do play interventions with your kids at home. It's all video driven. And actually the Health Navigator has this app library. Again, it's bewildering, but it does a really good job of reviewing apps and telling you whether they're decent or not, what their pros and cons are in particular. I do just want to mention there are some things we can all be doing at home. Obviously, some of these are really obvious, but worth bearing in mind, not just for people with TSC, but for families as well. Staying healthy, not necessarily, a restrictive diet. We know that can work for some people with epilepsy, but generally a healthy diet is better than a restrictive diet for most conditions. Thinking about our sleep hygiene, movement and exercise, music and play therapies seem to work really well for people with neurodevelopmental disorders. Encouraging independence, and there's one on the slide. The other thing that I am involved in is a trial where I don't think people with TSC can take part, but the idea is that irritability in people with autism might be caused by some gastrointestinal difficulties. And so the trial is about giving people these probiotic sachets. The idea is you reduce those gastrointestinal difficulties, it might improve people's irritability. So worth thinking about. These are the key things we know are really difficult, and I wish I had, a magic wand to solve them. But I think here's the key. What I think is I think you mentioned this really early, is lean on other people. Find someone who can support you. Find a champion clinician who you can pester, basically. Don't be afraid of being a pain in the bum. People are paid for that. Use those checklists and guidelines, take them to your clinician and say, this is what you should be doing. I think this is key, particularly for neurodevelopmental disorders. What are the key things that would make a difference? Is it that your child is able to do one thing? Just changing that one thing. Get your clinician or your psychologist or your behaviour person to focus on that thing, and from there you can build up. Document everything. I think we should all do this when we have any interaction with a health clinician. I like this term, be bold and benevolent. So don't be afraid to ask questions, be bossy, be awkward, but be nice about it. And self-care. Everybody should be making sure that they're looking after themselves as well as the rest of their family. Thank you. I'm not sure if I went over time.